So arteriosclerosis and atherosclerosis are two different things. So arteriosclerosis is the hardening of the arteries. And when we talk about that, it starts when the baby takes its first breath. When we take our breath of life, they say it starts to happen because it's an aging process. It's something that takes place as time goes on. Each time that heart beats, things are happening, and we do it every day, all the time for the rest of our lives. So atherosclerosis is the narrowing due to lipids. So we have lipids and there's plaque and stuff that will build up, and we can have atherosclerosis. And there's two different things. So arteriosclerosis is the hardening of the artery itself, and atherosclerosis is the artery narrowing due to lipids. Arteriosclerosis is the thickening of the artery walls that progresses to hardening as calcium deposits form. So when we have a arteriosclerosis, we're going to have blockage, aren't we? We are going to have blockage, and when blood can't flow through the vessels and through the heart, we're going to impede oxygenation, circulation, and it's going to affect our heart rate, our blood pressure, and all of that. We all know that you have to have your heart and your vessels and everything pumping like it should to live, to maintain homeostasis, to live. Atherosclerosis, also lipids are deposited within the vessel walls and combine with cells, fibrin, and cell debris to form plaques. So we get this plaque. So sometimes what we have to do is go in and we can push plaque up against the vessels and then blood can flow through, or we have to go in and there's a blade that can rotate and clean the vessel. There's a lot of things we can do in the cath lab. Cardiologists can do, interventional cardiologists. So there's a lot that can happen to help with this process, fixing it. Diabetes mellitus, speed development of both. So if you have diabetes and it's not controlled, then you're going to have speed development of both arteriosclerosis and atherosclerosis. And that's why diabetes is a silent killer. People will have no control of their blood sugars and not even know it because they live. The body will adapt, and as sugars start to get higher a little bit, the body just adapts to it. You don't even realize that you have higher blood sugars. And then eventually what happens is internally, that is all reaping havoc on the systems. It's going to kill the renals. It's going to kill the cardiac or the perfusion piece of our body. And that's why it's so vitally important that we control diabetes. Hypertension is a major factor in arterial sclerosis. So for my students, put that in your notes because you know what hypertension is. Now I want you to know it's a major factor with arterial sclerosis. That's the hardening of the arteries. So let's talk about it. What happens with hypertension? We're pushing, right? And we're going to go into more detail with it, but as we're pushing blood through, it's going to increase the pressures of what's going out and in of those vessels. If we're pushing through this little teeny doorway, a big elephant, what's going to happen? It can rupture the doorway, right? Same with arteriosclerosis. If you have kind of hard, crispy arteries and you try to push with a high pressure something through it, you can actually break or fracture, in layman's terms, those arteries, and it can cause a lot of issues. So you're going to see different terms. You're going to see PVD, which is peripheral vascular disease. You're going to see PAD, which is peripheral arterial disease. And you're going to see PVD at other things, and it can be peripheral venous disease. So just depending on what's going on, you're going to see those things. So understand that terminology. So if you're getting a report or you're reading a chart or something, you understand what's going on. But peripheral vascular disease is the narrowing or obstruction of peripheral blood vessels and loss of function. So that's what happens. It causes spasm of smooth muscle arterial walls, structural defects to the arteries, trauma, or an embolus. That's what can happen with PVD. How do we prevent it? We can decrease atherosclerosis and arterial sclerosis. We're going to control our diabetes and our hypertension, and we're going to prevent smoking or stop smoking. Now, smoking and nicotine, what it does is it will, it's going to contribute to arterial sclerosis. We're going to be, this right here, smoking, is going to make this rapidly increase also. So if a patient is smoking, you want them to quit. If the patient has quit years ago, just know there's been damage done. And so a lot of patients will come in with cardiac issues, and they're going to go, well, I quit smoking 20 years ago, but they smoked for 20-something years. And so it's still, they did a good thing by quitting, and it's great, and we need you to, because every day you quit, it's a better deal, but you've done damage. Now, my grandmother was a smoker, chain smoker, you know, brown on the fingers, never put one out. One was burning while she was smoking one. And when she had cardiac issues, her cardiologist said, if you'll quit smoking today, you'll add 10 years to your life. And the saddest thing is she started smoking at the age of 5 in the South. She worked in a tobacco farm with her family. They picked tobacco, and they all rolled and smoked that, all her siblings. And so she was 5 years old out there, and so she just rolled and smoked along with them. And so she started at a very young age. So she smoked she died at 72, so she smoked, I mean, you do the math, you know, 60-something years. So, but the doctor still had hope if she would smoke that she could add years to her life. But it was such an addiction for her that she wouldn't give it up. So just a little sideline. So this is a great diagram. This is showing you the major arteries of the lower extremity and the major veins of the lower extremity. When we're looking at anatomical mapping or anything like that, usually venous will see it as a blue because it's unoxygenated blood, and arterial will see as red because it's oxygenated within the system. And this is just a great picture because I want you to look at where your major vessels run. So if you're checking for a pedal pulse, right, dorsalis pedis artery, it's right here. If you're looking for the femoral, look at where it is, right? We're looking at different popliteal artery. That's why we can feel a pulse here. We push against that little bone and you can feel it, palpate it. But then the next thing is you have the femoral vein. Look at where they run. You can kind of see they kind of run side by side. So it's just a good picture to kind of study and look at where you're testing or assessing your pulses, where we're looking, because there are times that if we have no other access, it's very rare, but if we have no other access in the upper extremities, we'll come down here and put an IV in some of the veins in the foot, and we've put things into some of the legs, so it just depends. So it's a good reference, just kind of glance at it. It'll do you good in understanding where our major vessels are. So we're going to talk about PAD, or peripheral arterial disease. This is arterial insufficiency. So the most common cause is atherosclerosis. So just remember that is not the hardening of the arteries, but where the plaque builds up inside those arteries and causes a narrowing so there's no blood flow able to get through, or it's going to be compromised. One of the sign symptoms that you can have is intermittent claudication. And for my students, I want you to make sure you write this in your notes and understand this. So intermittent claudication is where there's pain in the muscles of the lower extremities. So what happens is at rest, you don't feel it. You feel fine because the body doesn't have that big of an oxygen demand when it's resting. But if you go to walk or exercise or do something, then you'll start to have this cramping in the calves, pain and cramping in your calves or lower extremities. You can have it in the buttocks and the hips, thighs, but mainly people see it in their calf muscles. And so it's that lack of flow. It's the circulation's being impeded, so the calf muscles don't get enough blood, so they're not oxygenating. So we have this. Some of the risk factors for intermittent claudication is smoking, diabetes, high blood pressure, high cholesterol, of course. If you have a family history of intermittent claudication or atherosclerosis, because that's the #1 cause for it. Then men older, 55 or older, and women 60 or older are at risk, and then sedentary lifestyles. So how do you treat this? Now, this is what's interesting, and I think that people always go, really? But exercise therapy is often the recommended as the primary treatment for IC, intermittent claudication. And the reason why is it improves circulation, and as you exercise, as they're moving, the body is going to create more blood vessels, which can ease the pain. When we talk about heart attacks, there younger men and women will fall over dead from a heart attack than an elderly person having a heart attack. And the reason behind that is as we age, we start to build this little microcirculation around major vessels. So in our heart, you'll have a major vessel, artery there feeding the heart the blood. But if you have slight blockage, what happens is it'll start to form little extra vessels. So if you shut a major vessel down, you still are going to get some blood flow to the tissue, unlike someone young who hasn't done that yet. So we want to keep exercising. The exercise helps people with intermittent claudication walk further without pain. So as we do that, that improves this exercise, walking, and physical activity. But it is the #1 choice or recommended primary treatment for this is exercise, walking. Get out there, get moving, right? Arterial ulcers, and we're going to look at a slide about this in a little bit, of what happens with tissue when it doesn't get what it needs. Arterial embolism and the 6 Ps, we'll go into that a little bit more. Older adult considerations, of course, as we age, we're going to be more prevalent to this because remember, as soon as you're born, you start to form these plaques within your vessels. It doesn't mean you're going to die as a kid, but it's a process. So we have these beautiful untouched vessels, and then we take our first breath and we start this process of aging. And with that, we start this whole arterial insufficiency slowly. So when you get into the older adult, when we're into that 70, 80 range, 90s, they're going to be at a higher risk, of course, for both atherosclerosis, for PAD, but also for arterial sclerosis. They are going to get the crunchy arteries. That's what I call it. Exercise and smoking cessation. So we'll go into that. But remember, anybody that's smoking, you want to offer them nicotine patches if they're in the facilities, and also smoking cessation information. And if they choose to go that route, there's medications and other things that we can do to help get them over the hump and off the cigarettes. Nicotine is not our friend, and I know it says smoking only, but we should add in vaping and we should add in tobacco products, because none of it's good for this situation. So this is a great picture, I love pictures, of femoral popliteal bypass graft. And what you're looking at is it's a procedure that creates a new route for blood flow. If you have a blocked portion of the femoral artery, which is a very large artery, right? If it's blocked, it means blood flow won't be getting down to the lower part of our extremities. So what they do is they graft. It's where they take a section of another blood vessel, or they can take a man-made blood vessel and sew around the blockage. You'll hear it called a fem pop, and that's what the surgery does. So we're going to talk about arterial embolus. Arterial embolus may cause acute occlusion of an artery. So more or less, it's a clot, a blood clot that is going to occlude arterial blood from flowing through an artery. No good, right? The most commonly cause for these are thrombosis that are formed in atrial fibrillation patients. So we have a lot of patients that come in with atrial fib. So as a nurse, it is your duty and responsibility that if someone is on atrial fib, has atrial fib as a rhythm, a cardiac rhythm, then you need to make sure that they are on a anticoagulant, because that is what's going to prevent them from getting these thrombus from forming. So atrial fib, what happens is the heart is firing. So it's an abnormal rhythm. It's firing, it's trying to capture, and then every so often it'll capture. But while it's fibrillating, because you think about how it's fibrillating, it's there. It's fibrillating. And while it's fibrillating, blood is pooling and sitting on the valves. And so when it's fibrillating and the valves are sitting there and the blood's just laying there getting little clots, what happens is eventually it will capture and it'll squeeze and pump. And when it squeezes and pumps, the valves will then let the blood flow and any clots just spray out throughout the system. And that's why they can go to the lungs, to the brain, to the extremities, somewhere, somehow, and occluding things from happening. No good. So always the anticoagulant, think about that. We want to never prevent arterial blood from flowing because we need it. It's the oxygenated blood. It keeps our tissues alive. The signs and symptoms of an embolus occlusion of an extremity are the 6 P's. Know them. Everybody should know them. Pain, pulselessness, poikilothermia, which is coldness, pallor, they're pale, paresthesia, that prickly tingling feeling, and paralysis, they can't move it, it's just nothing. These are signs of bad things, it's an emergency, and we need to get something going. It's bad. The 6 P's. Just remember those of arterial embolus. So let's talk about the differences in signs and symptoms of arterial and venous disease. So one of the things, let's just break it down, and I would do it on your notes like arterial disease and write these things and then out to the side put what they are. Then venous disease and put what they are. And you need to know the difference between arterial and venous disease. So for pulses with arterial disease, they're diminished, weak, or absent because we're not getting the flow, right? With arterial disease, there's a blockage, atherosclerosis, causing the blockage of blood flow. So that's why we'll have those pulses either absent, diminished, or weak. Skin is pale, dependent rubor, so it's got this reddish look to it, thin, dry, shiny, and cool to touch. Edema is absent or mild. Ulceration on the toes or at pressure points on the feet. They'll have a circular, smooth look to them, and they're on those areas. Necrosis and gangrene is likely. Pain, they have intermittent claudication. So when walking, they'll have that sharp, stabbing, gnawing pain. It lessens at rest. So when they stop, the pain should go away. Nails, thick, brittle. And hair, they'll have hair loss distal to the area of the occlusion. So if you see them with the lower extremity, a male or something with no hair on the legs and they have hair above it, that's a good sign of that. Now for venous disease. Pulses, they're going to be strong and symmetric, except sometimes they're hard to feel because they have edema, to palpate through the edema. They have a mottling with brown pigmentation at the ankles. Veins may be visible. Legs and feet are bluish when dependent. They'll have a dermatitis, and they are warm at the ankle, so they're warmer to touch. They present their edema. They're particularly swollen around the ankles and the foot, and they will have, it's a lot, and if they're dependent, they're going to have more. So, putting those feet up help, right? Ulceration is at the bones of the ankle, and they're kind of like, you'll see them, they're more weepy looking, a little bit different when you're out there and you can see the differences, but there's definitely, and I advise maybe Googling, I think I have a picture of it here in the slideshow, but we'll take a look. Necrosis or gangrene is unlikely with venous disease. For pain, they have aching, cramping, particularly when they have the extremities are dependent. So make sure you get those legs up because it's going to hurt them when they're down. It's also going to cause more swelling. And what do we know about venous blood? It pools, doesn't it? It goes down there and pools. So we want to help with it to get it back up. They're going to have normal nails and normal hair. So this is a great picture of cellulitis, if you see it. And when you're in the hospitals, in the clinic settings, look for people with cellulitis. they'll need to be treated. But sometimes things are overlooked or misunderstood. So it's very important. And when in doubt whenever you have a wound or anything like this, if you have a hospital that has wound care nurses, please reach out to them. It's a part of a protocol, I'm sure, in most facilities. And they are the experts. They know what's going on and they know how to treat things. And what they can do is work with the doctor, get an order to consult wound care and let them come in and do that assessment. And then you'll do the care once they come in, assess it, do the first care, then they'll write orders and stuff. The doctors will sign off on those and then you will perform that care. So this is gangrene of the toes. This is bad, 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 bad. I want you to look at this. All of this black is dead tissue. Nothing you can do with it. If you're not careful, you probably could touch it and they fall off. They'll break off. So we see a lot of gangrene with arterial disease. So what will happen is this person, and you see that there's all of this up here, and they're going to lose their legs. There's probably gangrenous issues and tissue up above that. So they're going to be a below the knee or above the below the knee amputation, most likely. So we're going to talk about aneurysms. Aneurysms usually are the result of plaque formation. You can get them genetically. There's a genetic predisposition for aneurysms and hypertension. No, hypertension. So remember, we're pushing, we're stretching. So an aneurysm is an outpouching of the wall of an artery, resulting in a structural defect in the layers of the arterial wall. Our walls are made to be strong, right? Our arterial walls. It's like a house. If you have a house with walls, you want them built strong so that when wind or anything else comes, pushes against, inside or out, they will not fall. Well, when we get this aneurysm, this pouching, it like makes a little pouch out, it is a structural defect. So what happens is it weakens the wall, that arterial wall. And if we have high blood pressure or anything like that, then what happens, the more we push against it, it can rupture if we're not careful. And that can be life-threatening. It's an artery. We're talking about arteries right now. Also, aneurysms can occur in areas weakened by trauma or surgical procedures. So not just, but there's these things that can happen. It occurs along the artery, and once an aneurysm develops, it continues to grow larger and may rupture. So people can have abdominal aneurysms and they'll get measured, and if they're not a certain size, they don't warrant immediate surgery. And a lot of patients will control their blood pressures, do all that they need to do, and they'll watch that aneurysm to make sure it's not getting any bigger or bigger to the point where that it could rupture or cause life-threatening chances, because once it ruptures, it's a major artery and they can bleed out and die. It's a biggie. So usually there's no obvious symptoms for an aneurysm. It just kind of is found unless they start to have, and like for a AAA, and you see the AAA here, that stands for abdominal aortic aneurysm. So if you hear someone say a AAA, that's biggie. It's not good. They may report back pain or a feeling of pressure that may have a visible pulsation on the abdomen. So if you see an abdomen pulsating, that is a sign of an aneurysm. Or that back pain that they have, and it could be even aneurysms can slightly seep if we're not careful before they rupture. I asked a cardiothoracic surgeon one time. I said, what is it? What does it look like? A AAA, an abdominal aneurysm, because they repair those, and they said it looks like when you take a straw that you drink out of, if you peel the straw, you remember how you used to spiral the straw down? You can make those little spirals with a straw. It's spiraled down and it's stretched a little bit. So you have the tissue of the artery is the straw, the harder part. And then in between is this thin tissue. And all it takes is for that thin tissue to rip or tear, and they're going to bleed majorly out of that giant artery. So when you're looking at, open up your old anatomy book or type it in your phone or something, but look up the aorta and where it follows down through the abdomen, and that's where you can see, and it's major. You know, it's a major one, so people can die. Aortic aneurysm in the thoracic area may cause substernal or tracheal pressure and difficult with breathing. So it just depends on where it is, but this is what happens, and both of these are not good. So treatment is surgery. We want to focus for lowering the blood pressure and treat the pain. We want to keep them comfortable, because what does pain do? What does pain do? It's going to drive the heart rate, right? It's going to drive the respirations, and it's going to make your blood pressure go up. Do we want a blood pressure high if we've got an aneurysm? No, we do not. So we need to get that blood pressure down and keep it down, and they'll keep it lower than a norm. You know, they bring it on down. And then we want to treat the pain, because we don't want them writhing in pain, because one, it's going to make everything go up, and we don't want things going up. So we've got to treat them with surgery. We've got to open it up and repair the aneurysm. And then we've got to keep blood pressure low and treat the pain, because we don't want it to rupture. So we can have Buerger's disease, and that's how you'll see it, but I want you to see the real name for it. It's thromboangiitis obliterans, and I just go ahead and say Buerger's disease. It just makes life simple. So it's the primary condition is not caused by atherosclerosis, but it involves inflammation and thickening in small and medium-sized arteries. So this disease process is not an atherosclerosis issue, but we're having this inflammation and thickening of the arteries. So they're going to thicken, and if we thicken anything, does it make them compliant? No, it doesn't, and it's also going to narrow the flow, narrow the vessels, so you're not going to get the flow you should get. We're going to have numbness and tingling of the toes or fingers in cold weather. Why? Because cold weather vasoconstricts, right? Things are going to constrict. They're going to shrink down a little bit, so it's going to make it even worse. So you're not going to get the flow that you need. Those little small, medium-sized arteries are going to be really teeny, and you're not getting the flow that you need. You're going to have pain in the feet, and you can have intermittent claudication. Once again, we're seeing this, and that's with Buerger's disease. So for treatment, we want to make sure that they quit smoking. Nicotine is not our friend by any means. Exercise. We're going to want to keep any kind of constriction of the vessel. What else is a vasoconstrictor out there? Caffeine. Does caffeine vasoconstrict? Yes, so no caffeine either. They will be on a diet that's no caffeine, low sodium. They're going to be on a cardiac DASH diet. And we'll talk a little bit more about that diet here in a little bit. We're going to teach the patient and reinforce the need for smoking cessation. So we really have to talk to them about it, because if they damage and these vessels go down, it can be life-threatening. So assessment of the extremities for skin impairment is essential, because it's not getting the flow that it should. And pain management is needed due to ischemic pain, so they can have ischemia. And this is not a good thing either. So Buerger's disease is for real, and people need to understand it. Another thing too is if it's cold, to make sure that they stay warm. We want to make sure that they stay, they don't need to be in cold areas. So the next thing that we're going to talk about is Raynaud's disease and Raynaud phenomenon. It's characterized by spasm of the arteries of the upper and lower extremities. So Raynaud's disease can be a primary disorder, or it can be secondary to another disease. So the other diseases where we see Raynaud's is lupus, rheumatoid arthritis, and scleroderma. We've already talked about rheumatoid arthritis, haven't we? So here we're starting to see other disease processes we've learned about, and things that can correlate or go along with or are part of these disease processes. So Raynaud's can be secondary to these diseases. I know a lot of people who have been diagnosed with lupus because of the Raynaud's. So they have these symptoms and go in to be checked and end up with lupus or RA. It is the signs and symptoms. The affected body part changes color. So what happens is when the spasm takes place, they'll go blanch out white. Their fingers and toes will go white. And then what happens is the spasm will relax, blood flow comes in, and they'll go to a bright red color, and they burn and throb. It is not good. I will tell you, I have Raynaud's. It's not diagnosed, but acknowledged by the physicians. So when I was under a whole lot of stress back years ago, I walked into grocery stores, and when I was under the stress, my fingers would do it. And I would blanch completely out, and then it would hurt, and then it would get bright red, and then it would go back to normal in time. So when I would go in, I would have to put mittens on or gloves on to grocery shop because I had to keep my hands warm. They couldn't get cold. So I would do okay, and then when I get back to the colder section where milk and stuff and the frozen food section, that's when I would have it. And then I got to where I was so stressed, I was having it all the time. So I just wore gloves in middle of summer and everything else. People probably thought I was crazy, but that's okay. It worked. So Raynaud's, lots of times, this is a picture of Raynaud's disease. And it looks a little different here. We've got blistering and you've got some black tips. Because the thing that happens is that it's lack of blood flow. And if we don't have blood flow, we have death to tissue, right? So the smaller arteries will constrict, they spasm, so there's no blood flow going, and then all of a sudden it can come back. But what happens is if they have this over a period of time, they can develop small ulcers or sores, and then these sores can actually become gangrenous, and they'll end up losing digit if we're not careful. So it's very important that we control and try to help folks understand keeping warm, different things. So they're not going to run out and play in a snow, have a snowball fight or anything like that, because they'll end up causing more constriction. It's something interesting to look up, but they'll go white, then red, or a blue color even, and then they'll come to a red when the flow comes back. So it's something to look up. Take a look, and if I can find a picture, I'll post it for you guys. So we want to make sure we don't constrict anything. So with Raynaud's, so we have stress control. Remember I said that brought it on. Avoidance of exposure to cold. We don't want to constrict anything, and smoking cessation. We don't want any nicotine issues, right? Because that's going to damage vessels and cause other issues. Calcium channel blockers can be given for treatment. And Ventivis is a synthetic prostaglandin alloprost, and it's another drug that can be given. Calcium channel blockers are one that I want you to know for my students, but just know Ventivis needs to go on a list somewhere, so that goes with Raynaud's. If you ever see it, you'll know it's a drug for it. I don't want you to really dig too deep into it at this point. Just understand it's connected, and that's how we treat. Nursing management, we want to teach this patient to protect those extremities and prevent injury. We don't need any injury. We want to avoid cold temperatures. They don't need to be living in Alaska. They're going to have to manage stress. How do we manage stress? How do you teach people to manage stress, right? We're all under stress. You're in nursing school. Life is stressful. Let's just go with that. But doing different things, and you need to start to figure out, is it exercise, which is always good for you? If it's yoga, self-meditation, journaling, whatever you need to do, painting, some type of playing with your dog, whatever, you need to manage your stress and figure out how to, because stress can kill you, and it's as simple as that. Stop tobacco use completely, and caffeine intake should be limited. We're not going to constrict. Just remember that. We want to prevent constriction. So when we're talking about superficial thrombophlebitis, we're looking at inflammation of a vein just below the surface of the skin, which results from a blood clot. You can get this from after using an IV line. We can see it. Sometimes symptoms can include pain and tenderness along the vein and hardening or a feeling cord-like. You'll visibly see a lot of this, especially if the patient is, it depends on where it is, I should say. You're going to have redness and tenderness along that course, swelling. These are some of the presenting symptoms that we see. Our body continuously forms small clots, and we break them down naturally. Alteration in this normal physiologic occurrence can be caused by several factors, and that's where we're seeing these superficial thrombophlebitis issues. So there's not a whole lot. I mean, they're going to have discomfort, so we can give analgesics. We're going to tell them to use compression stockings or hose, and that's going to help with flow. It usually resolves in 1 to 2 weeks, but the hardness of the vein may remain much longer. It might take longer for that vein to not be hard, and sometimes people, it looks like they stay hard for a very, very long time. I don't even know if they truly go away. I've seen people with that, and they get those cord-like veins that you see. You can put actually warmth or cold, apply heat or cool to it to help with the pain, and you can elevate the leg, and that will help. Now also too, actually, believe it or not, walking and stuff can still help, because we're going to increase blood flow, we're going to prevent anything from pooling or creating more clots, hopefully. Normally we actually create clots, and our body breaks them down. We always have little minor small clots going around in our body, microclots. And so those microclots our body takes care of. But if we have anything that interrupts that for some reason, we can have some of these superficial thrombophlebitis or clots that are formed right under the skin. So next we have DVTs, or deep vein thrombosis, and we all have heard of these. I mean, the majority of people out there have, and it's one of the biggest fears post-op surgical patients to develop a DVT. So how do we prevent that? Well, one, we get them up and walk them around as fast as we can. And secondly, we put on compression stockings. We'll also use SCDs, compression devices, to help shuttle blood so that it doesn't remain there's no stasis to it. It's not there static, just laying there. So we want the blood to flow. So how do we get a DVT? Prolonged surgeries. If they're in there for hours just laying, they are really going to be at a high risk for a DVT. Spinal cord damage and paralysis, because why? We aren't moving, right? Things are remaining kind of static, stasis is present, and chronic heart failure all contribute to venous stasis. These things, so when we're looking at chronic heart failure, CHF, we're going to look at people that are at prevalent or higher risk for DVTs, and we need to understand that. So immobility with the legs dependent in a car and airplane travel for long periods can also promote venous stasis. That's why it's so important if you're traveling that you get up and walk around. If you're on an airplane and you have any issues, or as you age, you're more prevalent too, then you want to walk around, but anybody can get one. The Today Show, I think it was the Today Show, they had a reporter, and I really liked him. I can't think of his name right now, and I hate that. But he went overseas to report on a military thing going on, and he got into a tank, and he rode around in this tank in the heat, and they were down in it, and he sat. He ended up with a DVT, and it ended up, he threw the clot, became a pulmonary embolus, and he died from it. And I think he was literally in his early 40s. Very, very sad. So you want to move. If you're in a car, you want to stop, make those stops. If someone's planning a trip across the country or up, even, for more than an hour, you need to stop and get out and walk around the car. I always say get up and walk around your car, and then you can get back in and keep moving. Also, you want to hydrate. Trauma and external pressure or internal pressure from hypertension may damage the endothelium, and that can cause this. Smoking, female hormone replacements, you're at a higher risk. So birth control, you don't need to be, if you're taking birth controls, do not smoke. Number one, you can have a stroke, major, but you can also be at a high risk for DVTs. Estrogen-based contraceptives, corticosteroids. If you don't know what corticosteroids are and do, and how they affect the body, you need to make a drug card or write this in your notes. Corticosteroids do a whole lot, and you need to look into them. They're a godsend in the sense that they save lives, but they can wreak havoc too on the body system if we're not careful. And then various blood disorders can contribute to hypercoagulability, and that can cause clotting issues. And we can see deep vein thrombosis, DVTs. So signs and symptoms of this, we have the pain, the swelling, redness, warmth at the site, edema. They hurt, and they hurt pretty bad, and they can swell a lot. It's not like a little swelling. They'll swell. The leg can double the size. Treatment, IV heparin, low molecular weight heparin, which is Lovenox we can give, oral anticoagulation, thrombolytic therapy, compression stockings always, they're a great thing. And if you're not wearing them yourself because you stand on the hard floors walking the hospitals or the clinics, or once you graduate and become a nurse, you need to protect your own circulation and vessels and body. And a vena cava filter if needed, so that we can filter clots. If they're having them or throwing them, we're going to prevent things from happening. So here's a great picture of someone with a DVT. You can see the difference in the size of the leg and the foot and the redness. Also too, that filter, if you end up needing a filter, the filter's a good thing. They'll place them so that you hopefully will not have a clot that will go to the lungs. You don't want a PE. PEs are what kill people. Clots going to heart, lungs, and brain are no good, no bueno. So you want to make sure that if needed, if they have a tendency to have DVTs or are having issues, they usually can get an IVC filter, and that's that inferior vena cava filter. And they put them in for this reason, so that it's usually put in up towards the femoral area is where they place them, so that if the clot breaks off, it'll stop into the filter. So varicose veins, they're not pretty, and unfortunately as you age, your vessels and vascular system can become more fragile. So I never had broken veins or anything all these years, and now that I've gotten older, I'm starting to have my veins break, spider veins and varicose veins. So they're enlarged and tortuous veins that are distorted in shape by accumulations of pooled blood. Treatment for veins include using elastic support hose. We need to make sure we're helping with blood, we're compressing and helping blood flow go back, exercising the legs and feet periodically throughout the day, and elevating legs whenever possible. So we're at risk being hairdressers, standing on that hard floors for long periods of time, not moving. Surgical nurses, wherever, doing whatever, we're at high risk for varicose veins. Like I said, hairdressers, anybody that stands for long periods, people that work in factories and stuff, they stand for long periods of time doing work, but they're standing. That's why it's important to have different mats, but they need breaks, they need to move, and if you have to, just step up and down and move the blood, get blood flow going. So chronic venous insufficiency, status dermatitis is common with this, and they also get venous stasis ulcers often because it is absence or damage of the valves in the vein. So you have this pooling of blood, chronically swollen legs, thick brownish skin around the ankles, and itchy, scaly skin. Not pretty. How do we treat it? Knee-high elastic support stockings and elevation of legs. And I want you to note this, for 8 out of 24 hours, that's a lot of time frame. So you want to elevate your legs 8 out of the 24. So kick those legs back. What's interesting about this is that, have you ever struggled putting on knee-high elastic support stockings on an individual? If you've ever had to put them on anyone else, they're very difficult to do. It's like wrestling a pig with grease, you know, it's just like everything. It's just hard. You're going to work and work up a sweat doing it. Put them on yourself, it's a workout. So it's very, very important that there's tricks of the trade of learning how to do that. There's this trick where you can use a plastic bag and put them on. So it's something good to learn. If anybody ever wants to show you, Learn the trick. It will help you when you're applying these to people and patients and yourself. So this is great picture, so you can see venous insufficiency. Look at the leg coloring and what you see. It is just not very pretty, is it? This is the characteristic skin changes that we see. So when you see this out there in the clinical setting, you'll be aware of what you're looking at. So venous stasis ulcers, we see them with diabetic patients with venous insufficiency or at high risk for venous stasis ulcers. So this is another thing to worry about if you're a diabetic and you have venous insufficiency. They have compromised circulation and they have a slow rate of healing. So they are hard to heal. Treatment, we want to elevate those legs. They're going to be edematous. You want to use a moist dressing and compression on them. So really what happens is you put the moist dressing, and lots of times they'll use ACE wraps over those dressings to help with these venous stasis ulcers and help them with healing. It's going to help blood push things in, help with edema. Remember, when you're wrapping anything, we wrap from below up. We want to move towards the heart. If you start high and move down, you're just going to cause more swelling below the wrap, and you don't want that. Dressings to be depends on what's coming out. If you have a lot of exudate and things, then you might have to change. And this is where I'm going to say once again, if you have a wound care nurse, a team at your facility or hospital or clinic, please, please, please reach out to them, because they're great at helping and wrapping and figuring out what these patients need so they can heal. Here is a picture according to the book of a venous stasis ulcer. So here we go. This is a great picture. I'm a picture person. So we have arterial on one side, venous on the other. I'm not going to repeat these, but here you go. Look at your arterial ulcers, round smooth sores, and then look at your venous. And I know the picture that we just saw looked like more like an arterial. They're calling it a venous, but I wanted you to see that ulceration because they can be pretty rough. So take a look at this, go through the signs and symptoms of each, and notice this leg is swollen. This one's not. Notice this discoloration, and this one's not, even though this one can, but it's this smooth looking. It's a little bit different on how it looks. Venous looks worse than arterial, I think, but either one is no good for the patient. So once again, you're looking at this. They say it's peripheral arterial disease. This is a picture. It's hard sometimes to see. It looks venous, kind of, sort of, doesn't it? So sometimes it's really looking into the chart, looking and seeing what's going on with the person. But just remember the signs and symptoms so that if you have a patient that's diagnosed with either or, you'll know what to do. This one, it says PAD and then it has edema there. Well, there could be slight edema. It doesn't look real slight there. There looks a little browning there with that, but there's that red look. But they have the shiny tout skin, and they're usually dry looking. Gangrene is prevalent with these folks. So I don't want you to look at this picture and go, that doesn't look like PAD the way it described it earlier. I want you to learn those descriptions and look, there's other pictures, but this is a picture we see quite a bit. And no matter what, if it's PAD or PVD, we need to do something. If it's arterial or venous, we need to be doing something. So just remember, these patients need help. I hope this helps, and I wish you the best, because we're going to see a lot of this out there, and hopefully prevent it with your loved ones, yourself, by doing certain things and following those rules and directions to prevent this from happening.